or functions have been damaged because of the immunocompetent cells or so you have an immune system causing damage instead of protection. And that's not good. So you end up by having certain conditions. The damage can be done by the cells or the antibodies. Now, if you recall, when we taught you the basic immunology, we told you that the different immune cells which can identify the self-antigens, they are all deleted. And the few ones which can manage to leave the primary lymphoid organs, that's the thymus and the bone marrow, will either be made
Recording in
so
progress.
that's a negative selection. Don't forget that sometimes even the few ones which may actually persist, we do have what we call conditioning by regulatory T cells, such that they are not able to respond. They are not able to respond. That's within the T cells. So the T cells which leave the thymus should not be able to recognize self-peptides. But a few of them, if they actually leave the central lymphoid organs, that's the thymus, they will be able to be made allergic or denied several things so that they can be there and they do not recognize the peptides. Don't also forget that within the same territory, we do have a negative loop which controls how much the T cell can respond. Technically, the issue of CTLA4, which is expressed by the T cells, they can inhibit the process, as well as again the T regulatory cells. That's on T cells. What about the antibodies? The B cells, very early on during the development, when they start expressing the mu or IgM, immature IgM B cell receptor. And remember, the B cell has B cell receptor, which is a service-bound immunoglobulin. And remember, that immunoglobulin is actually IgM and IgD. And recall that IgM is the first B cell receptor which becomes reorganized so that it can actually create a B cell receptor, a good B cell receptor, then followed by IgD. Now, so the process of pro immature and mature B cells, for you to remember that, you require to know that process. process. Now, within that, when the immature IgM receptor is being formed, and it can recognize that they can be able to actually identify or bound strongly to the self-antigens, as well as recognize the soluble antigens from cells. Those ones are actually, those type of B cells are removed within the bone marrow. They are removed within the bone marrow. Now, the second process, which can ensure that the B cells which leave the bone marrow are not able to recognize self-antigens, is they can undergo reorganization of the B cell receptor, through a process which we call the receptor editing. So the B cells which can recognize the self-antigens, the receptor can be changed by reorganizing the genes. So, but the B cells which entire clone can identify self-antigens, again, they will die within the bone marrow. Majority of them will die within the bone marrow. So there is what we call the central tolerance, which is within the thymus and the bone marrow. And there is what happens within the secondary lymphoid organs called peripheral tolerance. And both of them ensure that the T cells and B cells, which are in circulations, are not able to identify self-antigens. And as a result, the T cells and the antibodies produced by B cells are not able to cause damage. But something happens somewhere. So when that something happens where you lose what is called self-tolerance, you get what is called autoimmune diseases. And it appears that there are actually several factors that can trigger the autoimmune response. Our genetics, the type of the genes we carry, becomes very important in determining who is at a higher risk of getting autoimmune diseases, who is at a lower risk of getting autoimmune diseases. And we'll move on, we'll illustrate some of these as we move on. Then there is the environmental condition, and then issues of the hormonal suppression. For example, a number of autoimmune diseases are more common within the female gender. And obviously, infections will play a role with autoimmune diseases. So when you are asked the factors which trigger autoimmune diseases, you should be able to explain these four factors, how they interplay within all that, the four factors. Now, because we have actually defined the mechanisms which are used to evoke an autoimmune disease, and because it's going to be a combination of factors based on the genes, which are going to contribute towards the breakdown of self-tolerance, the environmental triggers, which will include infections, tissue damage. Now, we can ask ourselves, what then causes just to remind you, what then causes the autoimmunity? So, if you are actually asked what causes autoimmunity, I actually like seeing it is because you lose self-tolerance. You lack self-tolerance. Then if you lack self-tolerance, you can go back and explain you lack that tolerance, self-tolerance, because of all these factors, and you can move on, explain about central tolerance and peripheral tolerance. That's what actually happens. How then do you actually classify autoimmune diseases? Generally, we classify them into two: organ-specific and non-organ specific. And this is not a line drawn in between them. Sometimes one of the condition may involve actually multiple organs or actually multiple areas. Now, when we talk about organ-specific autoimmune diseases, you'll find that you'll be having antibodies which are going to destroy the cellular components of the tissues. So antibodies directed towards the cellular component of different organs. Now, those antibodies will either target the component of the cellular matrix, or if there is an antigen, foreign antigen, will be as a result of antibodies targeting that antigen and simultaneously targeting the cellular matrix. So the antibodies may be produced either against self or foreign antigen. And sometimes you find the antibodies which are going to be produced against foreign antigens. They may be able to target the self-antigen using a process which we call molecular mimicry. Molecular mimicry, which means the sequences of amino acid organization, which is being recognized by the antibodies, is similar to the sequences on the tissue. And therefore, when the foreign antigen is being targeted, the same antibodies will target the self-antigens, causing damage. Now, if you look for these antibodies for specific organs, and we do that every other time in the laboratory, you actually see the autoantibodies. You see the autoantibodies, and we will trace them to make the diagnosis of autoimmune diseases. And like I said, one autoimmune antibody or antibody may involve or cause damage to multiple organs. Now, there are organs which we know that you can have organ-specific autoimmune diseases. One of them is skin. The other one is thyroid. The other one is pancreas, muscles, and heart. And you are rotating in the clinical ones. You see some patients with skin conditions, which you hear our senior colleagues talking about diseases like vitiligo, which means that the skin is being targeted by specific antibodies. When you talk about the thyroid, you actually hear about hyperthyroidism and hypothyroidism. Pancreas, you hear people talking about type 1 diabetes, and muscles, myasthenia gravis, and heart, acute rheumatic fever. And diseases like acute rheumatic fever is actually very common. And when you check about acute rheumatic fever, it starts like just a sore throat. Beta streptococcal bacteria starts as a sore throat. But the antibodies made the antibodies made against the bacteria may end up actually going to target the heart cells, causing damage. So on the other side, we can now isolate all that those specific antibodies which are moved, like when it is skin, we'll go look at anti-tyrosinase. When it is thyroid, we look at anti-TSH, anti-thyroid cells, and beta cell cells, acetylcholine receptors, antibodies made against acetylcholine receptors, and so on and so forth. So you can be able to make a diagnosis after you have done the clinical examination. You've established that yes, there is vitiligo, and then you bring a specimen, you can go and now actually be able to identify. If you have conditions of a hypothyroidism or a hyperthyroidism, you bring a blood specimen, we can test for anti-TSH, anti-thyroid cells. We can test for that. If you have a patient with type 1 diabetes, we can actually specifically look for the B cell receptor antibodies. If you have a patient who has weaknesses in working because the acetylcholine receptors are not being activated, and I'm hoping you can remember your biochemistry and physiology, how the acetylcholine receptors work, then you can go and look for anti-acetylcholine antibodies, and so on and so forth. So that is on organ specific, and it is upon you now, and I assume my colleagues from internal medicine will teach each of these conditions, but in the meantime, you may go and check the clinical presentations and the management of all these conditions which I've mentioned as part of the autoimmune diseases. When we talk about non-organ specific autoimmune diseases, these are more common than the organ specific autoimmune diseases. You will have multiple organs damage, and more often than not, they will be because of actually circulating antibody antigen complexes, the so-called immune complexes, and the damage will be because of where the immune complexes have been deposited, and when the damage, removal of that immune complexes is being cleared, you may end up causing a damage. So deposition of the immune complex will be one of the things which will cause damage. Second is removal of that immune complex by mechanisms which may also involve damage to the normal tissue. Will be the second issue which you have to deal with. What are the organs which are what are the places which are more often than not involved? You find skin, joints, rheumatoid arthritis, skeletal muscles, brain, kidney, and blood vessels will actually be more often than not involved with the immune complexes related diseases. So most of them, they are connective tissue diseases. Connective tissue diseases. And then they will actually present themselves with those organs or connective tissues not being able to function the way they function. If you have actually joint, you find you are unable to move actually that joint, and when you move, there is pain. If it is kidney, you find that actually the kidney is actually compromised, and so on and so forth. Now, these are some of the diseases, again, which you will have to go and look at the clinical presentations and the management when you go back to your internal medicine, which are more often than not you'll find as non-organ specific autoimmune diseases. So SLE, systemic lupus erythematosus, a condition which is actually very common, especially in women, is one of them which you should know. And when you look at the antigen antibody, you'll find that there will be DNA and issues of nuclear proteins. Polyarteritis nodosa is the other one, and post-streptococcal glomerulonephritis becomes one of the most common. These are the most common conditions you are going actually to find. And therefore, when you examine these patients, you'll find that there is nephritis, vasculitis, arthritis, nephritis, again, depending on what you are going to do. Please note, I'm using the word TIS, which means that these places, there will be swelling. So almost everywhere I've put TIS, which means inflammation. So because of logging of the immune complexes, there will be inflammation. And because other cells will even come and try to remove these immune complexes, there will be damage causing inflammation. So inflammation will be one of the signs that actually you do have an organ-specific autoimmune disease. When you talk about these disorders, it's almost always good to know one of the causes, like we have said, is antibodies, autoantibodies. One of the causes is antibody. So part of the injury which is going to be occur is the presence of autoantibodies against self-antigens, either in the cell or the tissue. That's what causes the injury. So if you are asked about the injury, I want you to remember injury, the causative agent for the injury, number one, is the autoantibodies. Number two is the immune complexes. And number three is the presence of cell-mediated cytotoxic response. Those three are the ones which are causing damage. Antibodies, immune complexes, and cell-mediated cytotoxic response. Those three are the ones which will cause actually damage. So, and the damage when it is actually antibody is very well known that the circulating antibodies will go and bind to the antigens in the tissue or the cells. And when that occurs, we do not allow things to be where they are not found. Specific mechanisms will be brought into the area to try and remove that antibody and therefore actually causing damage. So organ-specific autoimmune. The antigen antibody complexes will be deposited in the vessels, causing either systemic or non-organ specific autoimmune system or autoimmune system. So it's always important to think about what will cause the damage. One of them is antibodies, the other one is immune complexes, and the other one is T cells. Now, for a long time, diseases which were actually related to the presence of the immune complexes were called serum diseases. So if you look at the literature of Von Paquet, he defines serum sickness in people who had actually immune complexes diseases. We no longer use that terminology. And he went ahead and defined the presence of fever, arthritis, skin rash, which occurred with or without antibody in the serum. And he went ahead and actually said symptoms will appear maybe after 1 week after exposure. And that's okay, because we know if you get an antigen, it takes like 1 week for you to get antibodies. And if you continuously actually produce the same antigen, you are making the antibodies which are going to be produced better, and more focused on that antigen. So the condition will actually become worse as actually time progresses. So it's important for you always to think about all that. Now, when you talk about the T cells, you know about the T lymphocytes, and please, when somebody talks about T lymphocytes, it's very different by somebody else who is talking about lymphocytes. Why? Because when you talk about T lymphocytes, you're talking about T cells. When you talk about lymphocytes, you include B cells, natural killer cells, innate lymphoid cells, all that. Now, the cells which are involved in causing the damage is CD4 positive T cells and CD8 positive T cells. CD4 positive T cells and CD8 positive T cells. And these may be specific for foreign antigens, which is going to be found in the tissue. Now, the condition will actually emerge because of what you may end up actually because of direct damage, or because of the cytokines which activate macrophage and go and actually cause damage to the tissue. So all these will end up causing inflammation. So the damage is either directly by the T cells or through the production of cytokines which activate the macrophage. And the damage which will emerge there will be because of activated macrophage. There are a number of what we call cell-mediated autoimmune diseases, specifically, and we've been able to identify the specific T cells. Diabetes is one of them, and rheumatoid arthritis. We think these two are as a result of a cell-mediated autoimmune diseases. But I'm not saying you may not end up having an involvement of the antibodies. So that's what usually happens. So there is cell-mediated activity within those two. But each of them has got an antibody-mediated component. Each of them has got antibody-mediated component. And that's not an issue, because we know that the B cells themselves can act as an antigen-presenting antibodies. And we know the T cells which have been activated through them, the T cells, the macrophage, when it picks a protein, an antigen, can end up actually presenting part of it to the B cells, for B cells to produce specific antibodies, and then to the T cells. So you can have all that. Now, I did mention some of the factors which are actually going to determine issues of autoimmune diseases are genetics. Now, in genetics, we teach you about major histocompatibility genes, which are genes which control tissue compatibility, and which are genes found in chromosome number 6, the short arm of chromosome number 6. We've taught you that it's polygenic. And to begin with, there are different classes of MSC, class 1, with genes like HLA-A, HLA-B, HLA-C, and class 2 being HLA-DR, HLA-DP, HLA-DQ. Those are actually important. So these genes seem to control who is susceptible to the autoimmune diseases. But we also know there are other non-MSC genes which have been associated with autoimmune diseases. Now, how do we know? We know, like in monozygotic twins, these ones have a high prevalence of diabetes type 1 as opposed to dizygotic twins. So if you followed the twins which are monozygotic and they happen to carry the certain genes, many of them with that gene will develop the diabetes type 1, and fewer zygotic twins will develop diabetes type 2. Now, more often than not, the class 2 genes are more often than not related to the autoimmune diseases. And we think there is what we call actually linkage disequilibrium, which a certain loci, a gene linked to a certain gene may be associated with autoimmune diseases. And indeed, people have mapped the HLA associations with autoimmune diseases, and they have been able to identify which HLA type will actually be associated with autoimmune diseases. So HLA type DR4, that's class 2. You find a number of patients with rheumatoid arthritis do carry HLA-DR4. Now, when you go to HLA-B27, you find that those people with HLA-B27 will have a high prevalence or a high increase of ankylosing spondylitis, 90 to 100% risk. Now, if you go to HLA-DR3, HLA-DR4, again, diabetes mellitus becomes, and DR2 lupus, the same with the DR2, DR3 multiple sclerosis. So this goes to tell you, because this is part of class 1, that HLA class 2 genes are more associated with autoimmune diseases. Just to go back to where I came from. Now, we do not know the precise mechanisms that define if you carry these genes, you are actually going to develop autoimmune diseases. We don't know. But we think somehow, somewhere, there is a failure of self-tolerance, and some T cells, which should have been deleted within the thymus, are able actually to leave the thymus. But we also think that HLA class 2 genes may influence the activation of regulatory T cells. HLA may activate. So which means the T cells, the regulatory T cells will make V will be present and will encourage the autoimmune conditions. But the overriding factor, we don't know what happens. Now, when it comes to infections, we know if you encountered certain infections, sometimes if you have an autoimmune diseases, you may cause a flare of that autoimmune diseases. But we also know if you get others, maybe there will be actually reduction in autoimmune response. But we also know that not every time when an autoimmune disease develops that you find a pathogen. Now, as a result, we think part of actually the way the infections causes autoimmune diseases is through inflammation, B, expression of co-stimulators, enhancing co-stimulators, and 3, cross reactions, what we call molecular mimicry. Those 3 may contribute to how the autoimmune disease occur when you have an infection. And I mentioned about streptococcal infections, which is common in children, and M proteins being targeted. So, so the damage again may be due to what we call the normal immune response. For example, tuberculosis, we know you end up having granulomatous. Hepatitis C infection, we know it will cause liver fibrosis. And coxsackie virus B, we know it can affect myocarditis. Now, whether this is what actually now causes the immune response towards the cell tissue, or because of autoimmune diseases, we don't know. Now, other factors which I mentioned hormones, and I did mention that autoimmune diseases are more common in women. And we know like lupus is 10 times more common in women than men. And this has been actually studied in the laboratory, So, and you can go and read about different hormones and the role we think they play in contributing to the autoimmune diseases. Now, trauma is important, especially in areas which have got sequestered antigens or privileged sites. We teach you in secondary about privileged sites, where there is a connective tissue which does not allow those antigens within that area to be present in the bone marrow and in the thymus, and therefore the immune system has not yet encountered these antigens. And if you cause trauma, you actually cause the release of those antigens. And the B cells and the T cells will see these as foreign and will end up actually causing damage. So if you have trauma on one eye, when all that happens, you realize that even the opposite eye will occur. If you're a footballer and you get orchitis on one testis, Don't be actually surprised if even the other testes becomes swollen because the sequestered antigens which had been sequestered in those areas, the trauma causes their release to the circulation, and for them to be identified, subsequently either T cells or antibodies will be formed. They'll enter the circulation, will go back and now target the specific tissues. So sequestered antigens is an important aspect. We have only a couple of minutes remaining. Now, all that knowledge has been used to design therapeutic approaches which can actually minimize or treat the autoimmune conditions. So one of them is, can we cause, because we know it's an autoimmune, it's immune system which is causing that. The direct approach is cause immunosuppression. Suppress that area which is actually causing damage. Is the main way we treat autoimmune diseases. And when you look at the drugs which are actually used, most of them are actually causing immune suppression. They are causing immune suppression. Now, we do have different classes of agents which have been used. To start with, more common things occur more commonly. Corticosteroids are going to be used. These we know they reduce tissue injury. Prednisolone is one of them. Hydrocortisone is also actually used in a number of things. Then you can provide drugs which inhibit the functions of the cytokines, especially pro-inflammatory cytokines. So you can have antagonists against interleukin-1, tumor necrosis factor. These will be used, especially tumor necrosis factor, are currently being used for the treatment of rheumatoid arthritis. Now, you can now also actually block the T cell activation. You know those things, antigen, the antigen presenting cells holding the peptide with MSC, and the T cell receptor recognizing that peptide which is bound to serve MSC, and then B71 and B72 and CD28 bringing the secondary signal to activate that, and the interleukin-2 being generated and causing the interleukin-2 receptor to develop on the T cell to cause proliferation and differentiation. So which means you can have drugs which inhibit this second receptor, the second signal. You can have drugs which inhibit the functions of interleukin-2 binding to the interleukin-2 receptor. That is actually one of the things we can do. And obviously, we can try and remove the autoantibodies using plasmapheresis, which will lower the concentration of the immune complexes, minimizing the logging of the immune complexes to the tissues which are actually where they are being deposited. So that is what I had to say within the time allocated. It's just a summary, but you need to go and actually look at this. Are there questions?
Thank you, Dr. Njagi.
Hello? Are there questions? Okay, if there are no questions, I say thank you and see you next time.
Okay, doctor. Thank you. Have a good evening. Good day.
Okay, thank you.
Recording stopped.